As we move into the next decade for graft-versus-host disease management, it's become apparent that global systemic immunosuppression is likely not the best way to proceed. All of us have started to look at other pathways in how to prevent and treat chronic graft-versus-host disease in hopes of mitigating the risk of that complication at the same time preserving the immune system of our recipient. A few other therapies have been studied recently and are worth mentioning. Proteasome inhibitors such as bortezomib showed promising results in single-center studies for graft-versus-host disease prevention. When taken to a large study conducted by the BMT-CTN, they showed no difference between a comparison to tacrolimus and methotrexate. We at Mass General have done a lot of work with the monoclonal antibody vedolizumab. This agent is approved for the treatment of inflammatory bowel disease and modulates lymphocyte trafficking, specifically to the intestine. There have been several anecdotal reports showing success in using this agent for the treatment of steroid-refractory intestinal graft-versus-host disease, possibly the most difficult subset of our patients to treat. And this past year, we published our results in a phase 1 study showing safety of combining vedolizumab with tacrolimus methotrexate for graft-versus-host disease prevention. And this has now been taken to an ongoing international phase 3 study to investigate its role in graft-versus-host disease prevention. Another agent that merits mention is alpha-1 antitrypsin. Alpha-1 antitrypsin is a naturally occurring protease inhibitor that generally causes modulation of the inflammatory response when given systemically. There are 2 reports that have shown its success in the treatment for steroid-refractory acute graft-versus-host disease. It is now being studied in larger studies, 1 for graft-versus-host disease prevention, and 2 national studies that will be studying for the upfront treatment of graft-versus-host disease as well. The last agent I should mention is KD025. This is an agent developed by Cadmin that is a ROCK kinase inhibitor and that has recently shown very compelling results for the treatment of steroid-refractory chronic graft-versus-host disease, and we anticipate that this agent may be approved in the near future for our patients. In terms of unmet needs, graft-versus-host disease remains quite difficult to treat. For acute graft-versus-host disease, the subset that is the most refractory and frustrating are those with acute intestinal graft-versus-host disease. And this subset of patients is what all newer therapies should focus on treating. For chronic graft-versus-host disease, the two subsets of patients that are quite frustrating are those with sclerodermatous graft-versus-host disease or those with pulmonary involvement, more commonly called bronchiolitis obliterans syndrome. Newer therapies for chronic graft-versus-host disease may have to become organ-specific as we move forward to try and treat these difficult subsets of patients. I think the challenges remain how to effectively conduct trials in a disease that's very heterogeneous. Trials for graft-versus-host disease have suffered because of the enrollment of patients who are probably biologically distinct, and thus any effect from a specific agent might have been lost in the noise of that heterogeneity. Also, all of our patients after transplant who develop graft-versus-host disease have many competing risks, and oftentimes these competing risks blurry the picture when trying to assess the safety or activity of any newer agents. Better ways to risk stratify patients for trials, or developing newer endpoints that are more accurate and represent what we're really trying to progress to are sorely needed.